Okay, just let me have everything ready.
Just a second. Yes. Hello, everyone. Welcome to our Zoom meeting. Today, we will have different topics. We're going to start with how to create infographics with Dr. Mohammed, and then we'll go over other topics. I'm going to share the screen with you guys just for the agenda for today. And I'm going to hand it over to you, Dr. Mohammed. When you are ready, please go ahead. Thank you. Dr. Mahasin, you can moderate the meeting.
Okay, hello, Dr. Nadir. How are you? I cannot hear you.
Excellent. Good. Thank you so much. How are you doing?
I'm great. But before we start our presentation, I have good news from one of our former fellow, Dr. Sheikh Al Tayyib. He's a PGY1 internal medicine resident on Pragdal University Hospital. Today, he scored 100% in his annual internal medicine exam.
Excellent. Very good news. Congratulations.
Okay, we can start our presentation. Dr. Mohammed, if you are ready, we can start.
Yes. Hello, everyone. My name is Dr. Mohamed Makkawi. I will be giving a brief presentation on how to make your own infographics so that you can share it with patients regarding various topics, depending on which part do you work as. So to start with, you can just first just type it in Google, canva.com. And the good thing about this program, it has a free and paid subscription. With the free, you can do a lot of stuff. Usually the paid subscription, you can do more stuff, especially with AI. But I'm just going to be doing with the free. So all you have to do first is you start. You can just make an account. It's very easy. If you just open from the menu, here you can find here you will be asked to just make an account with your email. Within 1 minute, you can finish this. Then you can find here this plus sign, create. Once you click this, you will be this menu will be shown. Here you can choose what type of design you wish to make for it. Now we're going to make infographics. So we can just simply write infographics. We'll be giving a lot of options. If you wanted portrait or landscape or about health, just start using the digital one. Once you double click it, it will show you to another open another tab. Okay. Then from here tab, you can see that there are many ready-made templates that you can use about whatever topic you want. Let's say now we want to make medical infographics. So you can just type medical infographics and you can see various types of templates. I already started doing one right here. I hope it's clear. Okay. So I chose this template about your health. You can also zoom it in. Yeah. So you can see this bar right here. You can increase and decrease the size. And then here, the good thing, you can just click and just replace any word that you wish. For example, if you want to change the disease, for example, I started here making about the flu prevention. So it was just given a generic example, disease prevention. So you can just remove it and write whatever disease you want to talk about. Influenza, for example, prevention tips. Then you can write briefly about what the disease is. For example, I just wrote the virus spread during the autumn-winter season. The thing about the infographics has to be catchy. You have to write few words, not write a lot of stuff and make it too difficult for the patients to read it. Because our aim here is to educate the general population. Then with using picture, the good thing here that this particular template has pictures. If you are not finding, if you want to make your own, you can either find if there is any other template that has the ones that that fulfills what you need, or you can design your own, but it's a bit difficult to do it. So I'll just use the ready-made template here. So for example, here, vaccinations. So I just gave a brief information about vaccination, that it's one of the best ways to protect you. And usually patients may have high expectations of vaccine. They may believe that it will give you 100% immunity. If I take the vaccine, I should not get the flu, but they will say that my cousin last year, he took the vaccine, but he still got the flu. Then they have to be known that the vaccine does not give you 100% immunity. However, if somebody does get influenza while he took the vaccine, it won't be as serious as somebody who didn't take the vaccine. And especially the vulnerable groups, like the children and the elderly, they're the ones who will benefit significantly from taking a vaccine. Then other things, for example, you have hand hygiene, then wearing of mask, a healthy diet, and sanitizing regularly. So this is just one example of how to make an infograph, for example, for prevention, for how to prevent certain disease. Then let's say that you just want to explain a disease. So this is one ready-made example. Hold on. So, for example, this one is explaining Fragile X syndrome. So they give a brief definition. It's not in English. So they give a brief definition of the disease and what are the common symptoms and some images, so that any person can get an understanding of what the disease is and how do you diagnose it, and if there is any, then you can write some websites where they can learn more about the disease, or if there is any contact you wish to give, you can mention it here as well. So this is basically on how to design an infograph using Canva. So this is about my part in the presentation here. If you have any questions, I'm ready to answer in the chat box. Thank you very much.
Thank you, Dr. Mohammed. Dr. Nadir, do you have any additional information or comment?
Excellent presentation. Thank you so much. Great, very useful.
Okay, Dr. Eiman, if you are ready, you can share your screen with us.
All right, Assalamu alaikum. Yes, I am ready. I will try to share my screen right now. And then let me know if you... Are you able to see it?
Not yet.
And how about now?
Yes.
All right. Assalamu alaikum, everyone. My name is...
Hold on, sorry. It's still loading.
Okay.
Try sharing again.
Okay, let me disconnect and try sharing again. I think we're good right now, correct?
Yes, we can see
Yes.
now.
All right, perfect. Assalamu alaikum, everyone. My name is Eiman, and I'm very happy to be presenting today the preoperative evaluation. Preoperative evaluation is optimizing patient safety and surgical outcome. So we're going to talk about if evidence-based, assessment, risk stratification, and medication management. What is a preoperative evaluation? It's a comprehensive assessment conducted before surgery to optimize patient health, identifying potential risk, and formulate a tailored plan for anesthesia and surgery. The primary goal is to reduce preoperative morbidity and mortality, and to enhance patient safety, and to improve overall surgical outcome. So the core component of the evaluation would be history and physical examination, risk stratification, baseline lab testing, and medication management. So looking into history and physical examination. So patient history is we'll dig into the person's surgical history. So this is previous surgeries, anesthesia experience, and complications. We also look into the medical history, which is chronic condition that the patient may have, like hypertension, asthma, diabetes, heart disease, or any hospitalization. Medical history is the medication that the patient is taking, and also put in mind any other things that could affect the anesthesia, like herbal supplementation or OTC drugs. We also need to know allergies, history on this patient, if he has any medication allergies, latex allergies, or any other substance. Also, we dig into social history, and we ask about smoking status, alcohol consumption, and drugs as well. Physical examination, that will be a cardiovascular system. We look into if the patient has any murmurs, arrhythmia, or any signs of heart failure. Also, for respiratory system, we see if the patient have any wheezing, crackers, or any airway patency. Neurological symptoms, we see we assess the cognitive function and the motor strength. A detailed preoperative assessment may identify conditions require intervention before surgery. Second, we go into evidence-based laboratory testing. Selective testing approach. It's a current guideline, emphasize selective preoperative laboratory testing based on the patient-specific factors and planned procedure. This approach minimizes unnecessary cost while maximizing diagnostic yield. Factor guideline testing selection, patient's clinical history, comorbidities, and planned surgical procedure. Indicated testing for specific conditions. So if the patient is diabetic, we need to go and look into his hemoglobin A1C. And the rationale behind this is we want to assess the glycemic control and identify higher risk patients. Also, patients who have renal impairment, nephrotoxicity, they're taking any nephrotoxic medication. And if there's any procedure that will be with contrast, we would like to see or test the serum creatinine and BUN. And of course, the rationale behind it is to access kidney function. We would like to do a CBC for patient who has anemia, bleeding disorder, procedures with anticipated blood loss to evaluate the hemostatic status. Coagulation studies like PT, INR, and PTT for bleeding or clotting disorders, anticoagulant therapy, or high-risk procedures to assess bleeding risk. Also, we need to check his electrolytes for any patient who's on diuretics, has renal dysfunction, significant comorbidities affecting fluid balance. And the rationale behind this is to evaluate fluid and electrolyte status. The cardiac risk assessment is a revised cardiac index, a validated tool to quantify risk of major adverse cardiac events in non-cardiac surgery. 6 independent predictors. These are high-risk surgeries, including intraperitoneal, intrathoracic, suprainguinal vascular surgeries, history of ischemic heart disease, history of congestive heart failure, history of cerebral vascular disease, perioperative insulin therapy for diabetes, and preoperative serum creatinine more than 2 milligrams per deciliter. We also assess the functional capacity assessment, which is the METS or METS, metabolic equivalent. Assessment of patient ability to perform daily activities. Patient unable to achieve 4 METs during daily activity may be increased risk of cardiac complications. Further cardiac testing indicated for patients with poor functional capacity, high-risk surgeries, specific cardiac symptoms, and when result would alter management. Preoperative medication management. It's a balanced risk of bleeding during surgery with risk of thrombotic events if medications are discontinued. So we're looking into antiplatelet medication and anticoagulant medication and when to hold on these medication before surgery and when to reinitiate them after the surgery. So aspirin, low dose aspirin, usually hold it 3 to 7 days before surgery for high bleeding risk procedures. And you do reinitiate them back 24 to 48 hours after hemostasis has occurred. Clopidogrel and tolterodine, 5 to 7 days. You hold the medication before surgery and you reinitiate it back 24 to 48 hours after hemostasis. Prasugrel as well, you hold it 7 days before surgeries and you reinitiate it 24 to 48 hours after hemostasis. So most of these antiplatelet medication, you do reinitiate them back post-surgery within a day or 2 days after hemostasis. But looking on the other side on the anticoagulant medications, and those are the warfarin, the dipicrine, the rivaroxaban, abivax, you hold them a little bit longer compared to antiplatelets. And most of them are held between 1 to 3 days post-surgery. You reinitiate them and you hold them between 2 to 5 days. Like, for example, warfarin, you hold them 5 days and you bridge with low molecular weight or UFH for next day. And dapagliflozin, also there are medication where you have to make sure that the patient, depending on the kidney function test, you may hold them a little bit longer or less compared to how perfect the kidney is working. Like, for example, the dapagliflozin, you hold them 2 to 4 days if the creatinine clearance is less than 50, and 3 to 5 days if it's if it's more than 50, and 3 to 5 days if it's between 30 to 50 ml per minute. So there's a lot of other encounters that play a role when it coming to the final decisions of these medication. Preoperative management of common medications. These are your antihypertensive medication, diabetes, thyroid, and steroids. So for antihypertensive medication like beta blockers, continue preoperatively. At the AC inhibitors and the ARB, you hold on day of surgery, and diuretics often held on day of surgery. Chronic steroid therapy, you continue that. Major surgeries, you give them a stress dose steroids based on baseline regimen. Diabetic medication, insulin, you adjust the dose. Oral hypoglycemic, most held on surgery days, and metformin hold within 24 to 48 hours. For psychiatric medications, most medication continue preoperatively, except the lithium, where you need to hold because of its renal excretion. Thyroid medication, like levothyroxine, generally continued. Antithyroid medication continue as usual. The key consideration is individualized approach based on patients, consider procedure-specific factor, and ensure continuity with the primary care. In conclusion, beyond clearance, preoperative evaluation extend beyond mere clearance to become a systematic process of a patient-specific assessment and optimization of risk. The key takeaway is systematic evidence-based approach to patient assessment, patient-specific risk assessment and optimization, and collaborative decision-making among surgical team. Thank you so much. And if you have any question, I'm ready and happy to answer.
Again, excellent presentation. Thank you.
Thank you so
Any
much.
questions? We can move on to the next.
Okay, I'm gonna share with you my screen, guys. So is it my screen visible for everyone?
Yes.
Yes.
Okay. So today we talk about the medical ethics and the legal standards in the U.S. practice. Okay. As international medical graduate entering the U.S. healthcare system, understand the American ethical and legal standards is essential. What we will cover today are the key ethical principle and the U.S. specific law like a HIPAA, malpractice, understanding the end life policy. So every healthcare system operate within its own legal and the ethical culture. Practice acceptable abroad, like a family-centered consent or sharing patient information casually, can violate U.S. regulation. For IMGs, learning U.S. Health system law early, prevent legal problem, and build patient trust. So this four ethical principle from the foundation of the medical decision making in the U.S. The first thing is autonomy, means respecting patient right to choose even if we disagree. Beneficent and non-maleficent require us to weigh benefits and harm carefully. Justice ensure fair treatment for all, regardless of socioeconomic or cultural background. So we have the first thing, the HIPAA, is the cornerstone of the medical privacy in the U.S. It's govern how we store and share and discuss patient information, whether written, spoken, or electronic. For example, never discuss patient details in the hallways or share identifying information on the social media. The second part is informed consent. Informed consent represent patient autonomy in action. It's not just a sign form, it's a dialogue. Patient should understand what began, done, why, and what could go wrong. For non-English speakers, always use a medical interpreter, not a family member, to ensure true understanding and the legal compliance. So the third part is malpractice. Okay, malpractice suits are a serious concern in the U.S. practice. To prove malpractice, the patient must show you owed them a duty, bridge understanding of care and cause injury. Include documentations, teamwork, and adherence to protocols protect you. Remember, transparency and empathy often help to prevent lawsuits after adverse events. Okay, end of life care is where ethical and legal issues often overlap. Patient may be express their wish through advance directive, DNR order, or POLST forms. Physicians must respect these documents, even if a family member disagree. In difficult cases involve palliative care or ethical consultation. Sorry. Early to ensure everything is okay, and all low flow curve. So for the IMG ethical, for the IMG ethical challenge often erase from the cultural differences. In some countries, families shield patient from bad news, but in the U.S., the patient has the right to know. You are also required to report child abuse, elder abuse, and certain disease by law. Understanding this expectation help you integrate it smoothly and avoid legal issues. The best safeguard is safeguard is pre-preparations. Each U.S. state has different medical law. To be sure you know your state requirement. Use ethical and the compliance team as resource. Ethics is not static. It involves regular CME in ethical health, maintaining professionalism and the patient trust. So to summarize this, ethical medicine in the U.S. means combining moral principle with the legal. Okay, following both ensure your patient are safe. Your practice is compliant, and your professionalism is respect. Thank you, everyone. So anyone have a question?
Thank you, Mahasin. Very nice presentation.
Thank you, Dr. Olla. You can start, present your topic.
Can you see my screen?
Yes.
Okay. Hello, everyone. Nice to be here. I would like to start by thanking Dr. Nadir for his time and guidance, and for the team for giving me opportunity to present today. I will be talking today about medical ethics and legal standards in the U.S. practice, the second part, which has two topics. The first one, documentation standards, and then I will talk about capacity, competence, and surrogate decision making. So let us begin with what the core documentation standards actually are and why they matter in every clinical practice. Clinical documentation serves as foundation of professional practice. The well-known maxim says, if it is not documented, it didn't happen. And it reflects both legal and clinical significance of accurate records. Documentation ensures continuity of care by enabling subsequent providers to understand the patient history and treatment course. It also functions as critical tool for quality assurance and medico-legal defense. In essence, documentation is not a peripheral task, but central professional responsibility. The core standards, there are two principal authorities that establish the framework for documentation in the United States. the Centers for Medicare and Medicaid Services, or the CMS. It mandates that documentation must substantiate the level of service built. This is require a clear record of patient history, physical examination, and medical decision-making. The Joint Commission, which accredits healthcare organization, emphasizes that records must be legible, timely, complete, and authenticated. Together, this standard ensures that documentation supports both the quality of care and the accountability of the providers. So the required elements in the US documentation, there are certain elements that are universally required in clinical documentation. These include patient identifiers such as name, date of birth, and medical record number, then date and time of each entry, and the provider's signature with professional credentials. Each note must contain an assessment and plan documenting the diagnostic, impression, therapeutic intervention, and a follow-up strategy. Interventions and the patient response must be recorded in detail. Correction must be transparent. Errors are to be struck through with a single line labeled as an error and initialed with the date. Alternations that obscure the original entry are strictly prohibited. Despite the clear standards, common pitfalls can persist. These include vague or incomplete notes, delayed entries, and inappropriate use of copy and paste functions, which can compromise the accuracy. Best practices emphasize prompt documentation, the use of objective and precise language, avoidance of jargon, and the maintenance of comprehensive and accurate records. Ultimately, documentation should present a coherent and reliable narrative of the patient clinical course, accessible to any member of the healthcare team. So, in conclusion, accurate documentation is not merely an administrative requirement, but a professional obligation that safeguards patients, support clinical decision-making, and protect the providers. Now to the second part of the presentation, which is capacity, competency, and surrogate decision makers. Let us start with an introduction to medical decision making. Medical decision making capacity refers to patients' ability to understand the benefits, risk, and alternative of a proposed treatment, including the option of no treatment. And it is cornerstone of informed consent. It is essential to distinguish between capacity and competency. Capacity is a clinical determination made by treating physician, and it is specific to the decision at hand. Competency, on the other hand, is a legal determination made by court, and it applies more globally. It's important to note that capacity is not static. It can fluctuate over time with illness or in different contexts. For example, a patient may have the capacity to consent to a simple medication adjustment, but not to a high-risk surgical procedure. This situational nature is why physicians must continually assess capacity, both informally in routine encounters and formally when concerns arise. When we evaluate capacity, we are looking for 4 essential elements. First, understanding. So we can ask questions like, can the patient accurately describe their condition, the proposed treatment and its risk and benefit? Second, appreciation. Like asking, does the patient recognize how this information applies to their own situation, rather than speaking in abstract terms? Third is reasoning. like asking, can the patient logically weigh the option, balancing the risks and benefit in a way that align with their values? And the fourth is communication. Can the patient clearly and consistently express a choice? Here, it's important to note that capacity doesn't require the patient to make what we might consider the right decision. What matters is the decision is informed, rational, consistent with the patient's own values. So when to evaluate capacity? Although we assess capacity intuitively in every clinical interaction, there are specific situations that warrant a more formal evaluation. These include an acute change in mental status, refusal of clearly beneficial treatment, or conversely rapid agreement to a risky or invasive procedure without adequate deliberation. We must also be careful in population at higher risk. We should be careful with population at higher risk of incapacity, such as very elderly patients or patients with psychiatric or neurological condition, or those facing significant language or cultural barriers. Evidence shows that physicians are often under-recognized incapacity. In fact, some studies may suggest that only about 42% of cases are correctly identified without formal tools. This underlines the importance of structured evaluation, particularly in high-risk settings such as in patient ward or among patients with dementia. So it is a structured evaluation approach, which is a stepwise approach that starts with step 1, which is to eliminate communication barriers. This may involve simplifying medical language, addressing hearing or vision impairment, or using interpreters. Failure to do so can create what we call pseudo-incapacity, where the patient appears incapable but is simply not being communicated with effectively. Step 2 is to identify and treat reversible causes of incapacity. These include delirium, infections, metabolic rearrangement, medications, side effects, or acute psychiatric illness. Then step 3 is to consider the patient values, cultural background, a refusal based on religious or cultural beliefs. For example, declining a blood transfusion in Jehovah's Witnesses doesn't in itself indicate incapacity, provided the patient demonstrates the 4 elements. And finally, step 4, which is directed clinical interview. Here we ask structured questions to probe understanding, appreciation, reasoning, and communication. For instance, we may ask, what do you understand about your condition? What do you think will happen if you refuse treatment? Such a question allows us to assess whether the patient is engaging in a rational decision-making process or not. When the clinical interview leaves us with uncertainty, formal tools provide additional structure and objectivity. There are multiple tools. One of them is the Aid to Capacity Evaluation, or ACE, which is the most widely used tool. It is a structured interview that directly tests the 4 elements of capacity in relation to a specific medical decision. It has been validated in large studies and has a strong predictive value for identifying incapacity. The second tool is the Hopkins Competency Assessment Test. Is another option. Unlike the ACE, it evaluates for more generalized incapacity, which is useful when considering transfer of decision-making authority to a surrogate. The third one is MacArthur Competency Assessment Tool for treatment, which is more detailed and comprehensive, but it requires more time to administer. In addition to these tools, we can use cognitive screening tools such as many mental state examination or Montreal Cognitive Assessment, which can provide supporting evidence. For example, a very low score strongly suggests incapacity, while a very high score supports intact capacity. However, these are not substitute for true capacity evaluation. This tool can assess the physician, but the final determination rests with the treating clinician. Now let us talk a little bit about surrogates. So when a patient is found to lack capacity, we must turn to a surrogate decision maker. Ideally, this is guided by an advanced directive or designated medical power of attorney. In the absence of this, state law provides a surrogate hierarchy, typically beginning with spouse, then adult children, parents, sibling, and so forth. In emergencies, however, physicians are ethically and legally permitted to proceed without consent if delaying care would risk death or cause serious harm. This is based on the pre-assumption that a reasonable person would consent under such circumstances. Now let us turn to surrogate decision-making in further details. So a surrogate is someone who steps in to make a choice on the patient's behalf, ideally preserving the patient's autonomy as much as possible. There are two main standards that guide surrogates. The first is the substituted judgment standard. Here, the surrogate tries to make decisions that the patient would have made if they were able to. This requires knowledge of the patient's values, prior statement, or religious and cultural beliefs. For example, if a patient has previously said they would not want to live on a ventilator, the surrogate should honor that. The second principle is the best interest standard. This is used when the patient preferences are unknown. In this case, the surrogate decides based on what would maximize the patient's overall well-being, weighing risks, benefits, and quality of life. It is more paternalistic, yes, but sometimes it is the only option available. Now, when no advanced directive or healthcare proxy exists, most jurisdictions follow a fairly consistent hierarchy of surrogates. At the top is a court-appointed guardian, if one exists. Next is durable power of attorney for healthcare. This is patient-chosen agent. If neither is available, the role usually falls to spouse or state-recognized domestic partner. After that, adult children, then parents, then adult sibling. If none of these are available, more distant relative may serve, and in some states, even a close friend or a caregiver can be recognized. The ethical goal in all of this is to respect the patient's autonomy as much as possible, while also protecting their well-being. Surrogates are not meant to impose their own values, but to either carry out the patient's known wishes, or if those are unknown, to act in the patient's best interest. And when disagreement arises among family members, physicians may need to involve ethics committees, or in rare cases, the courts. So, surrogate decision-making is both legal framework and ethical safeguard, ensuring that even when patients cannot speak for themselves, their values and dignity remain central for the decision-making process. Finally, it is always important to document your capacity assessment. We must record the patient responses, notes any tool used, and provide a clear rationale for our determination. This ensures transparency, protects patient rights, and provide legal and ethical justification for our actions. And by that, I will end the presentation. Thank you, everyone. If anyone has any question, you can write or ask me.
Thank you, Dr. Oda, for this amazing presentation. Dr. Nadir, do you have any comments or additional information?
No, great presentation. Thank you so much. Excellent.
Okay, Dr. Mohammed, are you ready?
Yes, I'm ready.
Okay, you can share your screen with us.
Hello, everyone. My name is Dr. Mohamed Makkawi. I'll be talking about mandatory reporting and advanced directives. Okay, so we have our obligations as physicians to treat the patient medically, but at the same time, we also have public health obligation. So we should also not just, our aim is not just to be with for the patient, but if there is anything beyond his medical needs, we also should be, if we are able to, we should also be able to assist them. So regarding reporting, we have two types of laws. We have mandatory and permissive. I'll be talking about it later. Okay, so this also includes infectious disease. If we have even suspicion of infectious disease, we should also report as part of our obligation to report it. All right, so we have mandatory and permissive reporting. So what is mandatory reporting? Here, in this, if there are certain cases that it is not up to our judgment. If we find a case which is under mandatory reporting, we have to report it, no matter what we think. And most of the states in the U.S. also punishes the physician if these cases are not reported. While permissive reporting, here the physician is allowed, but is not mandated, not compulsory for the physician to report it. So let's talk about some of them. We have infectious disease. This is quite a very important thing, especially since we have the advancement in medicine. Public health related to infectious disease. Since the 1850s, we were reporting diseases and trying to figure out what actually causes them, which led to a drastic reduction in these illnesses over the time. So we compiled, so the CDC, which is the main body in the US, compiled a list of diseases that if we have suspicion of, we have to report it in a timely manner to designated agencies. This is usually done depending on which hospital you're in. Every hospital have their own reporting system, and also some states require some diseases that they have to be reported while others not. So we have this may vary from state to state. So it is important to be familiar with what your state that you're working in requires. So this is just a table from the CDC talking about the infectious disease that are considered notifiable. You can see it's a huge list, and they may not be exclusive. And for one more thing, you don't have to diagnose the disease with lab. Even a suspected case, for example, a suspected case of cholera, you can report it without the need of laboratory confirmation. Now, another talk, we're going to talk about child abuse. Some statistics, child abuse, they were reported around 3.4 million in 2015, and nearly 2/3 of them actually resulted in the involvement of child protective services. And child abuse, suspected child abuse is one of those mandatory reports that all states in the US require reporting of suspected or confirmed child abuse. and even more, and most of those states as well will penalize the physician or the healthcare workers if they did not report it. So why is child abuse really important? Well, the thing is that they are particularly vulnerable, and are not usually free to express their own free will, or if there is if there is any issues happening around, either in the school or at home or anywhere. So usually in these instances, it is morally acceptable for the physician to set aside autonomy, which is usually a protected right. But in the terms of when it comes to child abuse, it is not done, not followed. And you can act as in loco parentis, which is like someone who works as a in place of a parent, either paternalistically or maternalistically, and then perform the duties that is normally society should be expected from a responsible parent. So there are certain signs that are common in child abuse. For example, if you find bone healing at different stages of healing, bone fragment different stages, with similarly bruising as well, inconsistent history. When you ask the parent once what happened to the child, they may say that the patient that my son fell down from the stairs. If you ask them after a while, he will say that he fell down from the sofa, and so on. So there is some inconsistency with the story that points you towards possibility of abuse. However, there are some issues when we are reporting child abuse. For example, some patients may complain. They may say that they may threaten lawsuits as well, that you are undoingly reporting me for child abuse, even though I am not. I do not abuse my child. And this happens. It's like, not every case that we report is actually a case of abuse. However, fortunately for us, that usually there are immunity laws that protect the physicians and other healthcare workers from reporting suspected abuse. So if we have a strong indication for abuse, usually there will not be any lawful issues against us. Then we have elder abuse. Similarly to children, they are also considered fragile, and they may not be able to help if there is any problems. So, however, elder abuse, unlike child abuse, is not very well done in all the states. Some states they make it obligatory and mandatory. Some others they don't. And also, even statistically wise, it's difficult to get a proper data on the true incidence of elder abuse. So it varies, and there are some estimates that about 10% of them experience abuse. So there are two factions when it comes to elder abuse. Those who support a mandatory elder abuse, they say that elders constitute a vulnerable population. They're either unable or unwilling to report abuse because they may be due to fear of retribution, or due to incapacity, they are not able to report the abuse, the neglect that they have. It's also important to note that abuse doesn't need to be that you have to apply something. Even neglect is considered abuse. Not feeding, not providing their basic necessities is also considered abuse. Then those who oppose mandatory reporting, they're concerned that reporting of competent patients would violate their own autonomy and confidentiality. And this is tricky, especially in another case when we talk about domestic abuse, domestic violence. It's more difficult because usually they will the one who is the victim will usually tell us not to report the one who is abusing her. So this will cause also distrust, because then the elder patient will distrust the medical system and will not come to the hospital if they need to seek treatment. Now we'll talk about DNR and advanced directives. So what is DNR? It's actually something that many people don't truly understand. So it's actually a medical directive that tells that I, as a patient, don't want cardiovascular resuscitation. Or so usually when we give a DNR, it is specifically to to not providing CPR. Like if my heart stops, I don't want CPR. But it can be extended towards other life-saving measures. If it can be given written in a part of DNR, we will talk about it later after a while. So usually it is requested by a patient who has terminal illness. So many times this talk about DNR usually happens at the primary office, or those who wish to avoid aggressive interventions that may not improve quality of life. And like I have said earlier, it only applies to CPR. Like only if the patient's heart stops, we do not do CPR. But that does not mean that we will not give them any other treatment. Like for example, pain management, palliative care. If the patient requires antibiotics, we will give them. If it requires fluids, we will give them. If require dialysis, we will give them. So DNR usually is signed, must be signed by a physician, and they're legally recognized in all 50 states. Though there may be some variations between states. Some states require something known as physician orders for life-sustaining treatment. Here, for example, if including the patient not wanting CPR, the patient may also request, I don't want dialysis, or I don't want fluids, or I don't want antibiotics. So they may have more end-of-life preferences. So usually they also fill this post. How it is done? Usually in the hospital, it will be noted down in the chart, and they're legally obligated to follow it. And if it is out of hospital, for example, in the community setting, patients may need a state-specific form, like for example, a specific bracelet or a wallet card. It's usually state for difference by state to state, and this will allow the emergency responders to know to fulfill his wishes. Some states like California and New York, they have this DNR forms, which are out of hospital. So how does this happen usually? Usually it's a discussion between the doctor and the physician and the patient. Like I said, most of the time it occurs in the office with your GP. So they discuss their wishes with the doctor, and then the doctor will issue the DNR based on the medical appropriateness and patient consent. And if the patient, for some reason, lacks patient decision capacity, like my colleague has been talking about earlier, a family member can request a DNR. So, what are the challenges that can happen with DNR? Usually, we have miscommunication. Like I've said earlier, most of the people think when we say that we are going to give a patient DNR, it means that we're going to let him die. We won't give him fluids, we won't treat him, we won't give him oxygen. So this issue has to be communicated well to the patient. And then sometimes you may not have the document with you. So, and like I said, various states have their different policies that can make it difficult, especially for the emergency, for the EMS. Then public awareness is also low. Generally, only about 25% of Americans have advanced directives. So what is the actual advanced directive? It acts as a substitute. If the patient, for some reason, is unable to consent, unable to give his own consent, an advanced directive allows the physician to carry out the best wishes, to carry out based on the best wishes of the patient. So usually it happens with those who are end of care or have chronic illnesses, or those who are elderly, and it is recognized in all states, but requirements may vary depending on the states. So it's very important for all of this ethics that we have to be aware of what the state requires in order to deal with all of these issues. So what are the types of advanced directives? Usually it's a living will. A patient will have a document that state that for example, patient, I don't want CPR, I don't want ventilation, I'm okay with dialysis, I'm okay with antibiotics. So they will specify what do they want depending on their situation. And then there is the power of attorney or healthcare proxy. My colleague have briefly talked about it. Here, the patient will entrust a particular relative. For example, usually they're their spouses, but it could be anyone. Someone that and they will have a legal document stating that that this person is my power of attorney in case I lose my capacity. And then we have the polls that we have mentioned earlier, where they will detail specific treatments if the patient wants or not wants. Then some challenges, usually they have low adoption rates. About only 25 to 30% of Americans have advanced directives. And then accessibility, usually emergency responses, they may not have access to this advanced directives when they arrive to the scene. And another issue, which is actually pretty common, that usually the advanced directive would be in vague language. Like they may just say, I don't want life-saving interventions. It could be anything. It could be intubation. It could be oxygen. It could be antibiotic. It could be dialysis. So it's kind of vague. So it's important that it to be clear and specific. And if you see in the USMLE, in the steps, usually the questions about advanced directives are very straightforward and very clear. In real life, it's very messy. Most of the time, there'll be no specific. The family members will fight. Some will say, yes, he doesn't want intubation. Some will say, no, he's fine with intubation, keep him alive. So it can be a bit messy. But if we're following as much as possible, we should be safe. And that is all. Thank you very much for listening. If you have any questions, you can ask.
Thank you so much for also great presentation. Any questions or any addition? If no more questions, we can move on to the next item in the agenda.
We covered the all topic of agenda.
Excellent. How about the updates? Anyone with any updates? Ryan, go ahead. Thank you.
Okay, Assalamu alaikum. Hello, everyone. Hope you're all doing. I would like to share a simulation app that I've developed recently. First of all, I would like to thank you, Dr. Nadir, for the opportunity. And I'm very excited to share the motivation behind the application first. The idea started when you shared the guidance on using Canva AI for the development of an app. And as someone with no prior coding background, I honestly didn't think I'd be able to create a functional app. So, which made this process interesting for me to explore. I decided to address a critical challenge we face in the department, the transition to online teaching due to the current conflict in Sudan. And as a result, many of our students outside Sudan now depend on peer reflection to have an insight and practical learning experience from the rural residency course. So this challenge motivated me to develop an interactive and engaging learning materials. And that is why I tried to develop this app to help them to develop the essential skills and competencies of the community diagnosis, which is one of the most important objectives of our rural residency module. So first, let me share the link for the app with you, and I welcome any feedback, and then I will share my screen to start the application or to try the application. Okay, sorry for the delay, I apologize. Okay, is my screen visible to you?
Yes.
Okay, so this is the this is the app. It is a scenario based about one of the most important competency or skills is community diagnosis. So I drafted the prompt and write the objective for the rural residency, and I asked the AI to form a scenario based on the WHO frame assessment of the health status of the population. So we can try the first scenario, for example, about the water quality assessment.
Ryan, can you share the preview or the published website?
Okay.
Because in Canva in Canva,
okay.
in Canva it's a small one. We cannot see the whole.
Okay, okay. Is it clear now?
Yes, better.
Okay. So these are the scenarios. First scenario, the first three scenarios about the Jazeera states. We have 5 questions on the water quality assessment in irrigation canal. 5 questions on malaria outbreak and in cotton farming area and schistosomiasis in school children. So let us start the first scenario. For example, you are visiting a village in Jazeera state where farmers report increased diarrheal disease. The village relies on irrigation canals for both farming and drinking water. What is your first step in assessing this health issue? So let us choose this answer, interview community leaders and affected families. The application gives you feedback immediately, and then we can continue. Water on the same scenario, which local health cadres would be most valuable for this investigation. So we can choose village health committee members. Yes, that's right. So it gives you very brief feedback. Village health committee members have direct community connections, understand local health pattern, and can facilitate community engagement while bridging formal and informal health system, and so on. So what environmental factor is most likely contributing to the problem? Let's choose this answer. Okay, environmental health requires understanding of upstream factors. So it gives learning feedback for the students. What immediate intervention would you recommend? Yes, distribute water purification tablets and promote boiling, and so on. So how would you engage the farming community in this solution? So work with farmers to develop sustainable practice and alternative water sources. So it gives us the score report. We have 5 out of 5. So and we can move to another scenario and so on. So this is the idea of the app. So I would be very happy to have any feedback from you. How can we modify it, and is it possible to modify it after publishing it on the website, and how can I deploy this and go further with this app?
Excellent. So if you share the screen again, I want you just to click on just for the fellows to see the first page when a user start the app. So here, yeah. So we have the app showing three regions. So you can, depending on where you want to teach or your learners, you can add more. Let's say you want to add any area. So in the prompt in Canva, you can mention, can you add another region? And you can specify 5 more questions or whatever. And these are the topics, 3 topics, similar to the Jazeera, for example. So in Canva, you can elaborate, you can add, you can edit, and it will revise and give you a better or newer version of the app. And then you click where it publish, you publish it again. So you have an option of unpublishing, I think, for the published one. So you can play with that as well. You can update the new version, or you can change the URL, the address, to make it version 1, version 2, whatever. That's another option if you want to. So this is the easiest way of doing it, and it can update. Excellent. Good. Great work. You're welcome.
Thank you, Dr. Nadir.
Thank you for sharing, Dr. Rayan. Any question or comment to Dr. Rayan? So one more suggestion is you can add, or in your prompt, add some links to references. For example, WHO, their website about malaria or about whatever the rare disease. If you have the location of that web address or PDF file or any information, maybe a video, you can add it in your prompt. So ask Canva to add this as a resources for whatever region or area, as a reference or as a resource for the student to learn more if they want to, if that makes sense.
Yes, very, very great suggestion. I will try to do it. to add reference and reading materials. Okay, thank you, Dr. Nadir.
Sure. And with current available videos, you can also review some of the videos on YouTube or other sites, maybe slides. There are different PowerPoint slides available in different topics also, and you can add this as also resources for the student to know more, to learn through videos, through PowerPoint presentation, and any other links or material that they can read. Thank you.
You are welcome. Thank you.
All right. Thank you again. Anyone else, anybody wants to share their app, if you are working on an app, or any new ideas, your projects, research projects, if you are working on a poster or any manuscript, you want to share your updated status. So I'm gonna share with you one thing that I want to show you some of the things you can do. I'm gonna share. So here, for example, the Google Forms you can create so that you can collect some information from your audience, from your learners, and so on, patients. And we know how to create the form, but for those who don't know how to, you can go to Google, and then you can go to your Drive, and in your Drive you can go new, and there is a way to add forms. You can create new form from blank, and you can use a template if there is already one used for you. But this time I'm going to show you how to do it more robust and maybe faster, effective way, depending on what you want to collect. So today, for example, I came to Gemini and I used a prompt where I asked Gemini, can you suggest some question for the fellows during our meeting? Today we have some questions. So it gave me a list of questions or ideas to ask you guys, for example. So I refined my question or prompt. Can you write this as a multiple choice question or yes, no questions, so that instead of giving you an open question, you can type and so on. I want to limit the question to be answered fast and quick. So it's a good idea to structure it in this way. So it gives me some options like progress and milestones and some questions here. So I wanted to find this more. So I asked some set for the meeting. For example, here are some goals for today's meeting. So we want to cover certain topics or certain items. So I wanted to create some questions about these. And finally, I used the output, whatever it gave me, and I refine it so that I can give you guys 4 questions or 5 questions. And I wanted the AI to write them so it understand my thinking. So it refined or rewrite the questions here, so in a polished format for me. So basically the current research status, writing, dissemination focus, skills, technology, and meeting engagement. So I have all the questions for you guys, but I want this to be an interactive. So I have to do it faster. The easier way or slower way is to use the forms from Google, create a new form and copy paste all this, but it will take some time for me. So I wanted the AI to write a script for me. So I asked it, now can you write a Google script to create the form with all these questions? So it's 5 questions, but I don't want to copy paste and spend a lot of time doing that. So Google script will help me create a form using the same questions that I asked. And this is the output. It created a script where this is the script. So basically it will write a function. It's a coding way of doing things. You don't have to go into the depth of details, but I'm going to show you how I did it. So some of you might do the same way or the other way of doing the form. So in this way, it's a Google script. So what you need to do is you go here, you say sheets.new, and then when you hit enter, it will create a new sheet for you, blank sheet. In extensions, you're gonna click and go to app sheets, and then it will open this area for you. And it's basically a programming area of the script area. So it's gonna have a sample 4 or 5 lines for you guys, and we're gonna delete this line. So 3 lines, these lines, we're gonna delete them. This is how programmers in the past, they used to program. So they write the code for the app to work on it. But for us, we're gonna come here and copy this script and paste it. So copy paste, and we can rename it project 1, for example, or whatever, questionnaire number 1, for instance. So you have the script, you have the name of the script, and then you can save it. After you're done, you can run it, and it will show you the final product. It's gonna be in a few seconds. You will have the form. It will ask for permission, you give the permission, and so on. So you give the permission, continue, and it will create the script for you, and it will create the form for you, and it will give you the link for that form. So this is the link for the form. If I copy that, if I put it in a new tab, it will show me the questions, and it will divide them into sections, and then the final for submission. So this is a form, and after you are done with the form, then you can submit it or you can share it with others. So for this demo, I'm gonna share this form with you guys in the chat. I want you to click on it, and maybe you can answer depending on what you think. For example, you have a project you are working on this week, or maybe you are busy applying for a fellowship or for the residency ERAS application. Maybe you can say no, and what you are doing if you are working on a project or working on a conference manuscript and so on. If you are working on an app, for example, you can answer. If you have new ideas or suggestions at the last question, you can answer at your suggestion, and so on. So I'm gonna share the screen again, and this time I'm gonna see how many of you are answering the questions. So it's gonna show us some of you. It doesn't collect your names or anything, so you can answer any questions. You don't have to be specific in your answers, just answer the way you think is right or convenient for you guys. So it's gonna come here, as you see there. So these are the questions, and these are the answers of the people who joined this meeting, for example, today. So this is how you collect some of the information using Google Sheet to address some of the questions. The method, you can use Google Form, the easier way if you have questions, or you can use AI and then try to collect some questions and answers, and then use script, Google script, to create the form for you in a faster way. It shouldn't take long, but it's one way of doing it. Any questions? Any comments?
Assalamu alaikum. At first, I'd like to thank you, Dr. Nadir, very much for your time and for your mentor. I'm relatively a new fellow, and I joined the WhatsApp group, and I want to know how to be part of a research project in this fellowship. So if you can help me with that, I want to join a research project team, for example. Or...
Excellent. Thank you so much for the question, and welcome to the program. So if you already joined the big WhatsApp group, then you can ask this question to see who is working on a current research project and see if you are interested in that topic. The other way is in your group, the small group, you can ask and see if your leader in that team or any member in the team are working on some of the projects, and you can join and see if you want to participate in one of the meetings. The other way around is to go to the app. So if you log into the TGRF app, there is a area where you can go to projects, and then there are different projects that are open, and you can have an idea about any of them. Some of them can be like, for example, this no one started, this one member, and this has 9 members in the team. So you can contact, let's say you are interested in the challenges of mobile application. So you can contact Dr. Aisha, and then maybe both of you can work on together. So to do that, you can just add me, and you can answer this question. You want to be a team member, you want to work on poster or whatever thing, and then so your name will be here, and then you can communicate with Dr. Aisha. If you click on it, it will have the email address and sometimes the phone number and so on for that person.
Okay, thank you very much. Really appreciate it.
You're
Thank
welcome.
you.
Thank you, and welcome again. Any other questions or any other comments? If not, I'd like to thank you all for attending this meeting, and thank you all the presenters for great presentations today. And I'd like to thank all those who will watch the recording in the future. Thank you, and I wish you all the best. I'm sure you are working hard to apply this year, and some might wait for next year. But for those who are applying this year, I wish you all the best, and let me know if I can be of any help. You can reach me via email, WhatsApp, or you can call me, email me. Thank you. Have a wonderful day, and appreciate your help with this program. Thank you.